Hello and welcome to another edition of our Facebook Live. After our medical rounds conversation, we hope you had a chance to see Dr. Wylie Hosmer. He is one of our remarkable oncologists, part of the breast program with the Hospital of Central Connecticut and the Hartford Healthcare Cancer Institute, which of course was the charter member of the Memorial Sloan Kettering Cancer Alliance. But what we're talking about, it is Breast Cancer Awareness Month. We're talking about screening, we're talking about precision medicine, we're talking about making people better. So we're going to dive right into this conversation, delving into precision medicine. How are we making, this is, you say an exciting, this is a time of tremendous hope for people who are being diagnosed. It's so terrifying, but yet there's so much hope, so much science.
Yeah, absolutely. I think, you know, we used to sort of think of cancers in very general terms, and we didn't really understand a whole lot about them. But as we've improved in the science, we've begun to look more into the machinery of what drives an individual cancer, thereby allowing us to really fine-tune our treatments in a more focused way.
That's amazing to me. And you think of, you know, for folks who are just now joining us, if you have been diagnosed and sort of medicine in the past treated everything, you are getting so much more targeted at making sure that you are attacking the actual cancer cells. Tell us more about that. How does that work? How do you know?
Yeah, so initially what you do is a large genetic evaluation of an individual cancer, and it's become possible to do, you know, to really survey up to 400 or more cancer-related genes in a pretty straightforward process that takes a week or less on a cancer. And what you hope to identify by doing that is a weak spot in the cancer, something that's different about the cancer than, for example, healthy cells in the body. And if you're lucky and you find one of these weak spots, then we often have a medicine that goes right after the weak spot, thereby treating the cancer but avoiding treatment or toxicity to any other healthy part of the body.
So we're reducing those side effects, and we had a remarkable story about a patient who was very open, who was very comfortable talking about her experience, and she, as she talked about that, one of the things that was so important to her, and I don't think she even knew going in it was so important, was that she never lost her hair. And even though that sounds sort of silly, it was so important to her. It made a big difference in her emotional health and how she responded to treatment.
Yeah, absolutely. So the patient we're talking about was able to participate in a clinical trial looking at a new treatment. You know, so unfortunately for many women with breast cancer, hair loss is part of the treatment, part of what comes with chemotherapy. And although there are other, you know, side effects that may interfere more with your life, this is a hard one because you see yourself in the mirror every day. So I think it's emotionally can be quite challenging for patients.
And I think that's fascinating because that was a big part of it, was that the outside world, she was able to sort of keep her, it's funny because she talks about it now, but she was able to keep her privacy. She didn't want to tell her parents. She didn't want to tell people at the time. Now that she is in a different place, she wants to talk about it and wants to remind folks that there are options. How do people get involved in a clinical trial? How do I know what's out there?
Yeah, so the key I think is just to ask. And you know, there are hundreds of clinical trials happening in this area and all over the country, of course. So the key is just to inform your physician that you're interested in a clinical trial, you know, asking, are there potentially other approaches? Is there maybe a less toxic approach? Is there a clinical trial that I might be a candidate for? And your physician should be able to help identify what's out there for you.
But I think that's a really critical point. I don't think that a lot of folks know, oh, is that on me? Am I the patient supposed to ask? I don't think people know that, so it's important.
I mean, in theory, obviously your physician should be bringing this up to you as well. And you know, I think just about anyone who takes care of cancer patients is very invested in clinical trials because we recognize that, you know, we need better treatments. We've come a long ways, but we're obviously not the whole way there yet, and we need better treatments. So, you know, every physician, I think, is invested in clinical trials, but it never hurts to be your own advocate. And so I think it always is reasonable for a patient to bring it up, to express interest in a research trial, and to ask what might be available to them.
As we get better at treating different cancers, you were talking earlier about immunotherapy. We saw this week that folks won the Nobel Peace Prize for this. So let's take that a little bit farther. Tell us why that is so exciting and how that works.
Sure. So obviously the immune system is a very powerful tool in the body, and we know that when you get sick with a cold or the flu or whatever it might be, it's really your immune system that fights that off. And what we've learned and what we've been able to do is to harness the immune system to fight against a cancer. And when that works, the cancer becomes like any other invading thing towards the body. It becomes like a cold or the flu.
Wow.
Just something else that the immune system fights against. And people will know that when you get a vaccine as a child, that immunity lasts throughout your entire life. You're protected against that illness throughout your entire life. So in theory, if we can turn the immune system on in the same way against a cancer, that might be an extremely long-lived treatment. And there are
can target those cells. It really is amazing.
It's remarkable.
We're also talking about, a lot of folks have written us with different questions. And again, this is your opportunity to talk to an amazing oncologist, one of our directors. But we do want to, we've talked a lot about very specific genes. There's been a lot of discussion about the BRCA gene and what that means. Take us through how that affects a body and what we're learning with those specific genes.
Yeah, so there's sort of an ever-expanding list of genes that predispose to cancers. And so I think, understanding your family history, understanding your personal risk, and understanding whether you perhaps could carry one of these genes and you wouldn't even know it is critical. And it's well known that there are many patients out there who would potentially qualify for genetic testing who may carry a gene but have never been tested before.
There are amazing, remarkable tests. I know that the Hartford Healthcare Cancer Institute's very involved in hereditary testing with the genetics counselors, this whole program to help people figure out what does this mean. When someone tests positive for one of the BRCA genes, what are those next steps?
Yeah, so that's obviously, can be challenging emotionally, physically, trying to figure out what to do. So, we've developed really here within the Hartford region a high-risk program that's specifically geared for patients that are at increased risk of breast cancer for whatever reason, whether it be a genetic or a strong family history. And the high-risk program is really designed to help guide patients through that process, to make decisions about how often should I be getting screening done? What age should I start getting screening? Do I need to be thinking about some sort of preventive surgery to help prevent cancer? What about my children? What are the implications for them and when should they be tested? Is there any medicine I should be taking to protect myself? Any lifestyle changes that I should be involved in? So it's really a very comprehensive group of goals to best care for those patients, and you need a dedicated team to do that.
And screening, I mean, you mentioned that so somebody does have a BRCA gene. You don't know that unless you're being screened, unless you're considered sort of high risk. Let's talk about screening. Our advances, once someone has been diagnosed, has come leaps and bounds. But how important are those mammograms? How important is it to get
screening remains critical. And if you can catch breast cancer at an early time point and treat it, then you might be able to avoid all the other stuff that we're talking about. And so there might never be a need for a chemotherapy or an immunotherapy or one of these targeted treatments. So really trying to catch breast cancers at an early time point remains critical, and mammography is absolutely the best tool that we have to do that.
We do have a couple of questions. So we had a question from Becky who said, listen, they found a cyst in my mammogram. Is that a sign? What do I do once I know that this has happened? We do want to make sure to leave it open for our questions.
Yeah.
I'm going to scroll through some of them.
Sure, absolutely. So for her, I think anytime there's an abnormality found on a mammogram, really the important next step is to get yourself in the hands of a breast surgeon or somebody who can evaluate that. Something like a cyst, may be nothing of concern, may not need any specific treatment, but there's a lot of nuance to this. And so I think it's scary, obviously, when something abnormal is found on one of these screening tests. And so finding your way to a breast surgeon, for example, who really can talk to the radiologist, determine how concerned are we about this particular finding, do we need to do any follow-up testing, do we need to do a biopsy? Those are all questions that come up after screening. And so I think the important thing is just making sure that the right people are evaluating and helping you make those decisions.
Okay, that is great advice. We had another question from someone who had a breast reduction much earlier in her life, and she was concerned, does that surgery lead me to be at greater risk down the road?
Not that I'm aware of.
Okay, so that's good
Yeah.
to know, a lot of folks. Now, I have another question, Betsy, who said, I know so many women who've been diagnosed in their 40s and 50s. Is the incidence increasing, or are we catching it?
Yeah, I think it's a mixture of both. And certainly we're diagnosing people at an earlier time point. In Connecticut, we tend to have relatively high rates of breast cancer as compared to other states around the country. And so certainly I'm seeing, a number of young patients with breast cancer. And I think that is a mixture perhaps of some increasing incidence, but also catching these at an earlier time point.
As more questions come in as we're looking at these, definitely let us know. You have the opportunity. You're talking with Dr. Hosmer with the Hospital of Central Connecticut and the Hartford Healthcare Cancer Institute. Some of the other questions that we were getting as they're sort of delving into the amazing advances in care. We talk a lot about sort of having that fingerprint, that blueprint for care going forward, for making sure that we talk about precision medicine. For folks who don't know what that means, how do you define that?
Precision medicine. Yeah, I think precision medicine is about understanding in a much more detailed way what really is driving a particular cancer. What are the underpinnings of this cancer, and can we focus in our therapies in a much more specific way? And so, rather than sort of treating all breast cancers as being the same thing, we perhaps can understand in more detail what's different about one breast cancer versus the other, and then be much more specific about how we're treating those patients.
What I think is remarkable is as we look at the history, tell us a little bit about when you first got interested in oncology, when you first started studying it, compared to, did you have any idea that we would be where we are today?
Sure, and obviously some of my older colleagues would, be able to expose much more on this than I, but certainly even within my, relatively short career, we've seen really dramatic improvements. There was no immunotherapy used routinely when I first, got into oncology. Very few of these molecularly targeted treatments were available. The cost and time to do the genetic testing to understand where the targets may be was much more expensive, much more time consuming. So it's really moved at leaps and bounds in the last 5 or 10 years even alone.
It really is remarkable. And I think it's really important for us to talk about what the Memorial Sloan Kettering Alliance is about and how that is valuable to patients right here in our state. It really was a deep dive. This was something that you worked on diligently together, making sure that your protocols were the same. For folks who don't know what that is about, who don't know what that means, tell us a little bit.
Yeah, I think there's probably 2 sort of very important things to say about the Alliance. One was that we, of course, wanted to make sure that the way we were treating patients here in Hartford, what our standards of care were aligned with what was happening at Memorial Sloan Kettering.
That is a big deal.
Yeah, which is a big deal. That's right.
That's right. Patients want to know that I'm getting right here the same treatment. That's important.
Absolutely. I think it's, of course, very scary when you receive a diagnosis, and I think people's initial instinct may be that I need to travel to one of these major cancer centers. And so to know that right here in our region, we've worked very hard to make sure that the way that we treat a breast cancer or a lung cancer is really exactly the same as the way it's done at Sloan Kettering. And so, I think that was sort of one important part of the Alliance, and then the other was the opportunity to bring these clinical trials from New York here to the Hartford region. And so a patient might be very interested in participating in a clinical trial, but the logistics of traveling to New York City on a weekly or twice a week basis, might be too much for that patient. And so if they can participate in the same trial without ever having to leave the Hartford region, that would tremendous benefit for them.
And tremendous benefit for science, for moving the whole field forward. As we look at sort of how we've moved all of this forward, all of these advances are due to these remarkable clinical trials. The folks who really want to take part to move healthcare forward. As you look at that, you were saying you're so thankful because these are patients who are going through so much, who at the same time want to be a part of that future of care and want to help people people who may be diagnosed well into the future.
Yeah, I mean, that's exactly right. I mean, every treatment that we use today, we know it's the right treatment because of a clinical trial that's happened previously. So really, we're making decisions based on firm scientific evidence. But that never happens if there aren't patients who are willing to participate in these trials. And, you know, they really are taking a leap of faith. Of course, when these trials are designed, they're designed in a very ethical fashion, and we, you know, do everything possible to assure good outcomes for patients. But you know, we don't always know all the answers. That's the reason we're doing the clinical trial. So it really is a leap of faith, and I applaud the bravery of any patient who can, you know, navigate receiving a cancer diagnosis, you know, thinking about its implications on their life, thinking about the kind of treatment they might have to go through, and in the midst of all of that, you know, agreeing to participate in a clinical trial. It's really quite remarkable, and without them, you know, we would never move the field forward.
And here at Hartford, we are actually creating a clinical trials unit that's very, very close to being open to our patients. This is so exciting because it gives options. Do you talk to patients? Are they afraid, or are most people very eager to sort of take part?
No, I think it's a mix. You know, some patients come in very clear that they want to participate in a clinical trial, but many patients are quite reluctant. And so I think that's about educating them. You know, this is the standard treatment. This is what we're interested in exploring in this clinical trial. These are the reasons why I think participating might be to your benefit. You know, these are the potential risks of the trial. So, you know, we have a full team of people who spend a lot of time talking to patients, educating patients, and helping them understand. So at the end of the day, patients, of course, make the decision that's right for them, but our goal is to provide them with the tools they need to make an educated decision about their treatment.
Where does tumor typing sort of come into this?
So, you know, tumor typing has gotten much more sophisticated, as I've, you know, said previously. You know, it used to be the case that a breast cancer was a breast cancer and a lung cancer was a lung cancer.
Right, this is fascinating how it's evolved.
And really it was defined only by where it started in the body, and really nothing more than that. But we've come to learn that there actually might be much more similarities between one person's breast cancer and another person's lung cancer, as opposed to a third person's lung cancer. So really what's underneath driving the cancer, you know, what's gone wrong in that cancer cell to create the cancer, understanding that allows us to type the cancer in a much more detailed way and hopefully make a more intelligent decision about how to treat it.
Remarkable. Well, before I let you go, I want you to tell us a little bit about your vision. What is coming next? What is the future of cancer care?
Yeah, I think everything that we've talked about tonight, you know, we're only going to see, you know, improvements. And so, you know, what I see is that we will continue to improve the success rate for patients, you know, hopefully curing more patients of their cancer, but at the same time starting to reduce the side effects, to allow people to receive treatment, but live a better quality of life during their treatment. And I think, you know, immunotherapy, we're probably just seeing the beginning of immunotherapy. And so what's to come, I think, will be quite exciting.
All right. Well, we are glad and lucky to have you as a part of it. Thank you so much, Dr. Wylie Hosmer with the Hartford Healthcare Cancer Institute. And thank you so much for watching.